Welcome to MED-MYSTIFY. I always like to think of the human heart not just as this mechanical pump, but as a highly sophisticated, beautifully synchronized electrical city. Just like a bustling metropolis needs a perfectly timed power grid to keep the lights on and the traffic flowing, your heart relies on extremely precise electrical impulses to pump blood efficiently. But what happens when that power grid shorts out? What if the master generator glitches or a wire gets crossed somewhere? Well, today in this explainer, we are going to master this electrical grid, demystify exactly what goes wrong during arrhythmias, and figure out how anti-arrhythmic drugs step in to fix the circuitry. Okay, let's dive into this. Here is our roadmap for today. First, we'll cover the normal grid. 2, the short circuits. 3, arrhythmia types and causes. 4, we'll be zooming into the battery. And 5, we'll unpack the technician's toolkit. Section 1, the normal grid, the normal cardiac cycle. Before we can play electrician and fix any broken circuits, we really have to take a macro view of the heart and understand the baseline normal flow of electricity. The sequential steps of a normal heartbeat begin with the master generator of our city, the SA or sinoatrial node. When it fires, the atria depolarize and contract, which is exactly what you see as the P wave on an ECG. Blood moves down into the ventricles, and that electrical impulse reaches the AV node. Crucially, there is a brief delay right here. This gives the ventricles time to actually fill up. Then, the signal just races down the wiring, through the bundle of His, the bundle branches, and right into the Purkinje fibers. Boom! That causes the massive ventricular contraction, your QRS complex, pumping blood out to the lungs and the body. Finally, the ventricles repolarize. They relax during the T wave, and the cycle seamlessly repeats itself. It is an absolute masterpiece of coordinated pumping and efficient cardiac output. Moving to section 2, the short circuits, how arrhythmias actually happen, because perfection is fragile, right? We are now going to look at what happens when this normal grid gets disrupted, causing the heart to be way too fast, too slow, or just erratically. So the first major glitch is abnormal impulse formation. This is when the problem starts directly at the power source itself. The pacemaker is the culprit. Sometimes the SA node fires way too rapidly, causing tachycardia. Other times it fires too slowly, and you get bradycardia. And occasionally, other rogue heart cells just decide they want to be the boss and start acting as pacemakers themselves, generating what we call ectopic beats. The result is an abnormal heart rate that drastically reduces the heart's pumping efficiency. The second glitch is abnormal impulse conduction. In this scenario, the SA node, our master generator, is actually working perfectly fine. It fires normally, but the wiring itself is faulty. The impulse hits a roadblock along the pathway. It might get delayed or completely blocked in the AV node, which we call an AV block. Or it might just get stuck in the bundle branches. Because the signal can't travel correctly, the ventricles receive an abnormal signal, leading to an irregular, uncoordinated heartbeat. And this brilliantly illustrates our third glitch, which is actually the most common cause of fast arrhythmias, the re-entry circuit. Normally, an electrical impulse travels in one direction and stops. But in a re-entry circuit, the impulse gets trapped. It travels down, finds a pathway that conducts kind of slowly, and then actually returns through another pathway, repeatedly stimulating the exact same area in this vicious, continuous loop. Think of it like a car stuck in a rapid roundabout. This causes a very rapid heartbeat, or tachyarrhythmia. Classic examples include AV-nRT and AVRT, like the infamous Wolff-Parkinson-White syndrome. Section 3, arrhythmia types and causes, the real-world impact. So those are the mechanisms, but what do these short circuits actually look like in a real patient? Let's pivot and examine the specific clinical manifestations and the triggers behind them. When we categorize arrhythmias by their origin, whether they start in the SA node, the atria, or the ventricles, we can see their direct impact on heart rate. An SA node issue translates directly to sinus bradycardia or tachycardia. If the atria go rogue, you might see atrial fibrillation, which is rapid and irregular. But pay really close attention to the bottom row here, ventricular fibrillation. The rate isn't just fast, it is chaotic. This uncoordinated contraction completely destroys cardiac output. As the data explicitly notes, ventricular fibrillation is a medical emergency that can rapidly lead to cardiac arrest. But what actually causes these glitches? The electrical grid doesn't just fail for no reason. Triggers can be structural, like coronary artery disease, a heart attack, or high blood pressure physically damaging the heart tissue. Others are chemical, electrolyte imbalances. Specifically, low potassium or magnesium totally disrupt the flow of ions. Certain medicines, like digoxin or even other antiarrhythmics, can induce them. And of course, lifestyle factors play a massive role. Excess caffeine, alcohol, smoking, or systemic issues like hyperthyroidism can all overstimulate or damage the grid. Everything from a massive heart attack to your third cup of coffee has a direct impact on this electrical circuitry. Section 4. Zooming into the battery. Cardiac impulse generation. Let's move to and see how this builds by shrinking ourselves down 1,000,000 times to look at the microscopic level of a single SA node pacemaker cell. The step-by-step mechanism of impulse generation is fascinating. Unlike ordinary muscle cells, SA node cells do not have a stable resting membrane potential. They are constantly drifting towards firing. In phase 4, sodium enters through what's known as the funny current, followed by a slow entry of calcium creating the pacemaker potential. Once it hits a threshold of about -40 millivolts, we trigger phase 0, rapid depolarization. Finally, in phase 3, potassium leaves the cell, bringing the voltage back down in repolarization, and the cycle immediately starts over. Notice anything missing? Pacemaker cells entirely skip phases 1 and 2 that you would find in normal cardiac muscle. And this brings us to an absolutely massive exam high-yield fact. If you take nothing else away from the microscopic physiology today, remember this. In cardiac pacemaker cells, calcium causes the upstroke in phase 0, not sodium. This is fundamentally different from standard neurons or skeletal muscle cells, which rely on fast sodium channels for their massive depolarization. The heart's natural pacemaker relies on a rapid influx of calcium to generate that initial electrical spark. Now, what's really interesting about this slide is the autonomic tug-of-war that dictates our heart rate. The nervous system acts exactly like the accelerator and the brake pedals on this pacemaker cell. Sympathetic stimulation uses noradrenaline to increase that funny current and calcium influx. The cell reaches its threshold much faster, leading to tachycardia or a faster heart rate. On the flip side, parasympathetic stimulation acts as the brake. Acetylcholine opens potassium channels, hyperpolarizing the membrane and decreasing that funny current. It takes much longer to reach the threshold, and that results in bradycardia. Section 5. The Technician's Toolkit. Anti-Arrhythmic Drug Classes. Now that we deeply understand the normal grid, the short circuits, and the battery itself, let's step into our final segment. Here is the Technician's Toolkit, the 4 classes of pharmacological tools we use to fix these specific electrical glitches. We start with Class I, our membrane-stabilizing agents. These are primarily sodium channel blockers. They target the membrane to stabilize erratic electrical signals, specifically by decreasing the rate of phase 0 depolarization in non-pacemaker cardiac cells. They are broken down into 3 subclasses based on their potency. Subclass A, like quinidine and procanamide, causes a moderate decrease. Subclass B, including lignocaine and phenytoin, causes a little decrease. And subclass C, with drugs like propafenone and flecainide, causes a marked, really severe decrease in phase 0. Next up in the toolkit are classes 2 and 3. Class 2 agents are our anti-adrenergic drugs, better known to most people as beta blockers. Think propranolol, esmolol, and sotalol. These essentially block that sympathetic accelerator we just talked about. Class 3 agents are the potassium channel blockers, featuring heavy hitters like amiodarone, britilium, and dofetilide. By blocking potassium efflux, these drugs specifically target and stretch out phase 3 repolarization. This significantly prolongs the time it takes for the cell to reset, which is incredibly useful for stopping those rapid reentry circuits. Finally, we finish the toolkit with Class 4, the calcium channel blockers, specifically verapamil and diltiazem. Let's link this directly back to that high-yield fact we highlighted earlier. Remember how the SA node relies entirely on calcium for its phase 0 upstroke? By blocking these calcium channels, Class 4 drugs directly slow down the firing rate of the heart's natural pacemaker and slow conduction through the AV node, making them exceptionally good at treating arrhythmias that originate above the ventricles.
So, the crucial point is that by understanding the physiology, the pharmacology makes perfect sense. I'll leave you with this final thought to ponder based on everything we covered. Based on the pacemaker action potential, how exactly do calcium channel blockers prevent arrhythmias? Like, subscribe, and share this with your friends for such more pharmacy-related informative videos. Be sure to write your questions, suggestions, and thoughts in the comments section. We will catch you in next one.